Thank you for coming this morning, everyone. Lovely to see you all. Nice to see a full room as well. So my name is Joanne Browne. This is Linda Jenkins, my colleague. We work for Lymphoedema Wales and we currently run a national cellulitis improvement programme. So we want to talk to you today about how we prioritise proactive management. How do we set those goals in place for those patients to stop the recurring incidences of ill health? So the aims of the session today, we were discussing the importance of proactive care and where it sits in our current NHS model at the moment. But importantly, we're going to be talking about those specific principles that you might be able to incorporate into your areas of work, how we've incorporated it into our programme, and we'll be giving you some examples as well of where this all sits within our programme. So just to give you a bit of a background as to what we do, as to why we set up our programme of work. We know that there's lots of data out there about patients who suffer cellulitis. Just to recap, cellulitis is a bacterial infection of the skin that is quite often associated with legs. So we know that there's thousands of bed days occupied with patients with a diagnosis of cellulitis, and these patients are quite often admitted through emergency departments. There are thousands of pounds attached to each of these patients on every admission. So it stands to reason with this kind of care, is there something more that we could be doing to prevent this? So the aim of the programme was set up in order to increase patient awareness. A lot of patients have never heard of cellulitis until they've been given that diagnosis, even less so how they come to get that infection. We want to reduce the incidences of recurring cellulitis episodes as well, and we do that through assessment, education and that treatment of that identified risk that can lead to that infection. But I think one of the most important ones, one of the aims is that we're also talking to healthcare professionals, because a lot of patients don't know about it and a lot of healthcare professionals are equally unaware of the dangers of cellulitis. So this is already thinking about that proactive model in terms of how we set our clinics up. So what? Why do we need to do this? We've already explained a little bit about the hospital admissions, but there's a lot more to it than that as well. There's all these risk factors that we've identified that also add on to this perfect storm of unwellness. So we know that the recurrence rates for cellulitis can be anything between 10 to 50%. I think what that tells us really is that if you've had one, you are very likely to get another one. 38 of those patients have lymphedema. Now there is a link between lymphedema and cellulitis, as we all know, but there's lots of people out there who don't understand that link. I think I can put my hand up as one of those people 10 years ago working in the ambulance service, going to these patients with cellulitis, having no idea how they became so unwell and taken them into ED myself. But 1.4% of all those admissions are for cellulitis. That's incredible. And in Wales, hundreds of thousands of GP events, that's that same person turning up again and again with those recurrent infections. And the misdiagnosis rate as well. There's lots of signs and symptoms that mimic cellulitis. So already we can see there's a kind of it's like unpicking a big picnic blanket, isn't it, of where the problems are at. What can we target to prevent that end point admission there? Do we have time to care? Do we have time to do something about it? When they're in hospital, it's easy for that treatment to take place. It's easy for the IV antibiotics, the restabilising of that patient condition. And this is the model that's been existing for over and over again. But what does it mean? What does it mean when we got to get the right care in the right place at the right time? Does this relate to illness? In hospital it does. We go into hospital when we're unwell. But does this relate to health as well? Does this relate to providing that care at the right time when that patient is healthy, to manage those risks, to stop that deterioration? So at the moment we have this kind of cycle of reactive care, don't we? If we look at the diagram there on the left hand side, we've got that cellulitis or that wound present. This is where all the NHS resources are targeted at getting that wound better, getting that patient back on their feet again, literally. But it's very intensive. There's lots of service involvement. Quite often, wherever you work, you might feel the only person involved in that patient care. But what happens then is they get discharged from our service. The risk is still there. Their wounds have now healed, but those problems are still there. That lymphedema in those legs, the skin creases there that might lead to a fungal infection. And then what we have then is this kind of this constant pre-wound picture where that patient is at risk of that infection or that wound reoccurring, but there is no strategy in place to reduce that. We're just waiting for the next incident. So then this is where we look at how can we be proactive? Why do we need to do that? Well, we have a delay in that health deterioration. If we can get involved at that point, we can delay that onset of the next cellulitis infection. Independent living, a lot of these patients have lots of comorbidities. They have lots of problems managing on their own. We need to promote shared accessible services so these patients can access these different areas. So for example, packages of care, social support, other healthcare factors, podiatry, etc., so that they have access to those services. We need to reduce these episodes of ill health in order to stop the burden on unscheduled care. We need to address these patient complexities through that access to those services, through independent living. The social economic factors that quite often go with these issues are a factor. So it's about acting on these different aspects before patients reach crisis point. So within our service, within the cellulitis service, we take a kind of the perfect patient, isn't it, at the moment? What's their profile of the patients that we're seeing? So we know that they cover a whole range of comorbidities, such as blood pressure problems, heart failure, diabetes, vascular problems. Cellulitis doesn't just occur in a vacuum. All these different elements impact on that. We know that frailty is a serious issue. Some of them aren't quite so frail, and it has been in a younger population, an idiopathic infection, but quite often there's a vulnerability attached to these people too. So we need to target that. And what we want to set up then is this cycle of proactive care. So this is where we normally intervene here, where there's a wound, but actually we think we should be targeting these areas here. So if we've got someone with healthier legs because they've been given that education message from our clinics, we can manage those risk factors. We can empower those patients to manage those risk factors. We can't always reduce the fact that someone will get a wound, but what we can do is plan for it a little bit better. We can target those clinics for those patients. We know that they're not going to be in our services for quite as long because those risk factors have already been managed, and it makes our plotting of clinic time with these patients easier to manage, shorter involvement. But this is where our main element can be targeted, on that patient education, on that risk factor management, on that relevant service involvement. So the big question is, how do we do this? So Linda's going to give you a little bit more of this in detail. So I'll just cover the basic principles here. So it's not just about treating what's in front of you. It's not just about treating that wound as they've come to you at that crisis. It's about looking at all those other elements. What other services do you need to help you with your patient? Do they need podiatry? Do they need wound care? Do they need care of the elderly? Do they need a package of care? Are they claiming attendance allowance? Antimicrobial stewardship is absolute key, which Linda's going to talk about a little bit more. What's the patient telling you? What's important to them? Where's that data? How can you target what's important? And what's that other data telling you about benefits, trends and costs? So just to give a little demonstration, I think this is the poster that we have that kind of addresses some of those accessibility problems. Our plan is to put these up in all primary care services. It tells you a little bit more about the fact that if you've had antibiotics, contact us. We can help you here. So I'll hand over to Linda now to give you some more detail on that.
Change places.
Yeah. There you go.
So as Jo mentioned, I think what's a bit alien to us generally, certainly from the field that I came from before I worked here, was that lots of places you're trying to reduce the amount of referrals you're getting. You're trying to almost put people off referring a little bit. Lots of services make it very hard to refer in and therefore decrease the numbers of referrals they're getting. But what we're doing is send us it. We'll accept anything. An email, send us a name. We need a name and an NHS number, and then we'll find them. We use Consultant Connect, which I think might exist in England too, as well as in Wales, which is a phone number that healthcare professionals can use to access lots of different services and get advice over the phone and accept referrals that way too. And we also allow patients to refer to us. I know PIFU is a nationwide sort of initiative, patient-initiated follow-up. So often when you might have discharged a patient, particularly with chronic conditions, things that might tick along quite nicely for a while and then have an exacerbation, we want to see them and make sure they don't get as many exacerbations, but make it easily accessible if they need help, and not have I've got to go to my GP, I have to get re-referred, then I sit on a waiting list, wait for 6 months. And they're the ones then who don't ever want to be discharged, because they know that if they do get discharged, it's really hard to get back in with you. So if we make it easy so that patients know, when I ring up and say, I'm having a real crisis, my legs are leaking, we can say, that's fine, we can see you next week, because we're no longer seeing people routinely every 3 months and every 6 months, whether they need it or not, and clogging up our clinics with all these patients. So we use a PIFU model. We see them, we sort them out, we treat them, we get them stable, and then we say, right, when you need us, you get in touch with us. And that might be never again, or it might be in a year's time. Stewardship, antimicrobial stewardship is a really big talking point, I think. It's one of the World Health Organisation's sort of big health crises, is how are we going to manage our antibiotics, isn't it? And in the UK, they've just recently released the Confronting Antimicrobial Resistance guide. And within that, there's various themes, but these top two here kind of sit with us. Within the team, quite a few of us are prescribers. Jo and I are both non-medical prescribers. And so I think the main aim of our service is to reduce the need for people to ever have antibiotics. So if we can see them, identify their risk factors, get them self-managing much better, so they're much less likely to get a cellulitis, then they're much less likely to need antibiotics. We can also make them know what cellulitis isn't, because there's an awful lot of people who will say, my legs are red, so I get antibiotics. Well, how do you do that? Well, I ring the doctor and I just say my legs are red again, and they just give me them over the phone. And that's most likely not cellulitis. It wasn't helped by COVID, where a lot of this kind of, I just ring up and got antibiotics. And so we're trying to educate patients that that isn't cellulitis. You don't need antibiotics for that. And the healthcare professionals too. So reducing the need for antimicrobials through sort of education, and then optimising the use. So stewardship around things like the prophylaxis and things like that, people that have been on prophylaxis for a really long time. When do we start them? When do we stop them? Optimising that we're using them when we really need them. So they're the kind of big ones for us. And that doesn't mean we never ever prescribe. And there are, we're not perfect. There are times when I'm sitting there on a Friday afternoon. We don't see many acutely unwell patients. I wouldn't want an acutely unwell patient to wait for their clinic that's been booked in with me. You'd want them to go to access their primary care, as they should do. But occasionally people do turn up with an acute cellulitis, and you're just thinking, is this inflamed? What's your leg normally look like? How much different this looks like it could be? It's 3 o'clock on a Friday. And so you can see why you're just like, I am going to give you antibiotics because I think this could well be, and I don't want you tipping into an emergency admission, a sepsis. So it's not, there isn't a perfect storm, but in the main, obviously people do need antibiotics when they're unwell. Swabbing? Question mark. Big push to try and reduce the amount of swabbing that gets done. What are you achieving by swabbing? What are you hoping to achieve? Patients love swabs, don't they? Oh, the nurse has been out. Oh, she was worried. She swabbed me. And it's growing bacteria. Of course it has. Yeah, of course it has. You've got a big wound there. It's going to grow bacteria, but then it's really hard to justify why you're not giving them antibiotics. So think about the rationale for swabbing. I would only really, and I've never really swabbed somebody, but in hospitals, and I can appreciate it does happen, would be if someone's clearly not very well, they're on antibiotics because of that, they've got this wound, they're not getting any better. Are we going to swab them? Are we going to take bloods to look at, have they got an unusual bacteria here? Is that what's making them unwell? They're not responding to the correct antibiotics. And yeah, like I say, stopping antibiotics when people may be on them unnecessarily. So they're the things that we're going to be, that we are looking at. We do a lot of PROMs, patient-reported outcome measures, to ask patients what's important to them, because we can think what we think is important to them, but it mightn't mean anything to them. It mightn't bother them at all that they've got a hugely swollen arm. They just take the fact they have to wear a sleeve and come to an appointment every 6 months, and we've burdened them with that. Whereas ultimately they'd like to be going soon on a Friday afternoon with their granddaughter and then baking a cake with her and not wearing the sleeve that means they can't wash their hand. So we've got to think about what's important to them, and equally people who have very little swelling might say that it's ruined their life, and that they're really struggling with it, and and they're finding things really difficult. So by asking people how they manage with cellulitis, so we send them a PROM when we first meet them, before we've really intervened with them, asking them whether today now, even though their cellulitis was 3 months ago, do they still feel the impact? Is it impacting their work life? Financially, are they impacted? Do they worry about going on holiday? Does it still give them any pain? Do they have a fear of having another infection, which is usually the big one? And ask them what they're thinking of. So we get them to score all those things out of 10, and then we can address them with them in the clinics. And these are some of the scores that we've had. So these are the pre and the post scores. So before we meet them and the last time after we've seen them. And they also leave comments for us on there as well. There's free text on there, which is often really powerful, so we can, find out what is impacting them and what is making them feel worse. So the National Cellulitis Improvement Programme was born initially to target patients who had been admitted to secondary care and given a code of cellulitis. So we would send letters to everybody who had been admitted, and we started off going back 2 years. When we first started this in 2020, we'd say to a hospital in South Wales, send us the numbers of all the people who have been coded as cellulitis in the last 2 years, and they sent us this big cohort of people, and we did every hospital in Wales in turn like that, getting all those data, and then we went back a year later and did the same again, and now we get the whole of Wales every 2 months because we've been around all the hospitals. So every 2 months we get about 700 people's names for those people who've been admitted to a Welsh hospital with a diagnosis of cellulitis, and we send them a letter and we say, we hear you had cellulitis, or we think you had cellulitis, do you want to get in touch with us and we'll speak to you on the phone and see if we can help reduce your risk factors. So that was the first push. Let's target secondary care. This unscheduled care, that all these people being in these hospital beds. And then after that, and partly pushed by COVID a bit, because we started in January 2020, partly pushed by that, we targeted GPs. So we started inviting all GPs to have an education session with us so that we could tell them what we were doing, let them know that we existed, tell them what was available to them to refer patients into us, particularly those troublesome ones who maybe they were seeing quite frequently, but generally people who are having cellulitis. And by doing the education session, which was predominantly over Teams, which worked well in COVID, was face-to-face if they wanted it, but predominantly over Teams, we were then saying to them, refer to us, you can just refer to us, and they'd be like, really? What about so-and-so? She lives in her own home, she can't get to an appointment. We'll do a home visit, it's fine. Just refer people to us and we'll sort it out. So that was phase 2, and that's ongoing, that's still happening. Phase 3 then, we realised we were missing a bit of a trick with primary care for patients who weren't getting admitted. So there's a large cohort of people obviously who don't need admission with cellulitis. They have their antibiotics, they don't become too systemically unwell, and we keep them at home. And so we were targeting them. So what we do is work with the pharmacists who are often attached to GP surgeries. They do some audits for us and look at who's had flucloxacillin twice in a 12-month. So flucloxacillin really commonly used for your skin infections, obviously, and not really used for a lot else. So they would send us the names and the details of the patients who had had two flucloxacillins within the last year, and we'd send them a very similar letter to the inpatient saying, we can see you're having some problems with your skin, you're having antibiotics quite frequently for your skin, get in touch with us and let's see if there's anything we can do. Have they got risk factors too? Can we be impacting them? So that's them. And then phase 4, as a sideline of that, we were kind of coming across people who are on Pen V, so quite a lot of prophylactic antibiotic. There obviously are some people in there with their splenectomies who might be on that long term regardless, but there were an awful lot of people who were just on it, get started by somebody and never get reviewed, and so we were going to look at them too. And out of that then, the most recent collaboration has been the work with the heart failure teams that we're working with around Wales, looking at the risks of their patients having cellulitis. Quite risky people of becoming unwell. So if you've got heart failure and you're living with a little bit of swelling and you get a cellulitis, you're probably going to go in hospital because you've got those comorbidities. So if we target those vulnerable people and get them into some relatively easy hosiery and give them a bright advice, are we going to stop them being admitted? So they're the kind of phases of the programme after they've gone through, and this is just a bit more info and just a kind of example of there is information out there. I didn't do this. I wouldn't know where to start with getting the data for every health board in Wales and how am I going to get that? But it exists and it's out there. So the pharmacists who helped us with the audits just pointed us to a website that you can do this. So you can just put in, this is all the health boards. So in Wales there's 6 health boards and each one of them is a different colour, and this is their fluclox usage per 1,000. So this pale blue one here is Cardiff Health Board. Cardiff classically got quite a young population, quite a studenty kind of place, as well as a lovely place for me to live. So they tend to use less flucloxacillin than, say, Cymtaff, which has got the highest obesity in the whole of Wales, and so lots of skin problems and things like that. So you're just comparing health boards on that one. This one I used for when I was doing a presentation about the education programme. So the black line is all Wales use of flucloxacillin over a couple of years. It's every quarter you get how much flucloxacillin Wales has used per 1,000. So that's the black line, pretty consistent up and down trend. The blue line then is a GP cluster in Swansea. So on average, what that GP cluster use. So different clusters will have slightly different graphs because they might be in a more deprived area, an older population, those kind of things, so you can compare like with like. And then this red graph was one GP surgery and their use of flucloxacillin. And this here is when we presented to them about using flucloxacillin and the education around that. And you can see that when we presented to them, they massively dropped their use of flucloxacillin. So use the data to sell yourselves. You know, I was like, let's have a look, see what happened after I did it, put it into the search engine and it comes up for you, and see that can prove your worth then and show that it is working and it's something that we can do. So that's just an example of how you can use data. And this is using data and using, again, information that I couldn't put together, but the financial delivery unit in Wales helped us with this. So we told them, we've seen, you can't quite see 4,000, that's 4,977, so 5,000 people had completely been through the programme at this point. And we knew how many episodes of cellulitis they'd had in the last 12 months because they could tell us that. So between those 5,000, they'd had about 5,300 episodes, so just over one each. And we can break that down into costs. We know how much it costs for them going to the GP, how much it costs if they attended emergency admissions, how many nights they were in hospital, how many IVs they had. So you can kind of cost that out and figure that those 5,000 patients cost about £15 million to the NHS in Wales in that previous 12 months. If we work on the premise that about between 10% and 50% will have a recurrence, like Joe said, we kind of know the recurrence rates, it's quite high. So if we say, well, between 10 and 50 are going to have another episode, we'll work on that lowest figure. We'll say, okay, 10% are going to have a recurrence. If 10% of them had a recurrence, we'd be talking about 498 recurrences. And that would equate to this cost. If they went in hospital, saw their GP, we'd be talking about 1.5 million. So that pool of patients that we saw should have cost another 1.5 million the following year if we work on averages. In actual fact, because we saw them and we know the information, there were only 171 episodes of cellulitis in that time. Like I say, it's not a perfect thing. We can't guarantee you're never going to get one. What we're doing is reducing risk. And the associated costs with that are 144,000. Obviously, we cost money. So if they didn't have us, they wouldn't have had that cost. So you've got to add that cost on too. But it's still a huge saving. And if we had a 50% recurrence rate, if we'd gone to the top end and said, well, half of them are going to have a cellulitis and be admitted, you'd be talking about £7.5 million. So these are the kind of things that when you present them, then you've got a really good, oh, okay, fair enough, we can see why they're doing that, but we'll give them a band 7 and let them do, let them expand that service a little bit more and work a little bit more. So this was a lady that Joe saw, so I'm going to switch back again so that Joe can talk you through it, because it's just a good example to have a case study.
Yeah, I think it just really illustrates pulling all those principles together as to how it can work. So we kind of got a bit of reactive and proactive care going on here. We have a lady who's been admitted to hospital with heart failure and cellulitis. First of all, we wouldn't have known about her had it not been for the heart failure collaboration. She wouldn't have appeared on our radar. But we've got lots of complexities here. The cellulitis, the lymphedema, the wound, but the mental health that goes with that as well. Her mental health was suffering really quite, it was declining quite rapidly because of that being in hospital. Her frailty as well. This is a lady who was normally able to walk about, now confined to a wheelchair, and as you can see, a Zimmer frame to walk. That patient reported data, I can't move, I don't want to live. That's as bad as it gets as far as I'm concerned. So lots of involvement here. So we reached out to all these different services. In hospital, they have their own specialities, but we came in from the community to get that patient out. So we were looking at heart failure, lymphedema, cellulitis, in-reach services, TVNs, mental health, occupational health. These services all exist. It's very intensive because she is at that crisis stage. But actually, the real treatment comes afterwards for us. It's about that antimicrobial treatment. This lady wasn't on prophylactic medication. There is a real need for this in patients like this with a really high recurrence. That prophylaxis keeps that bacterial involvement suppressed. So this is where it can be really good here. That self-management, how to manage your legs, how to stop or raise the alarm if you find that you're starting to overload with fluid, if your legs are starting to leak, how to access those services. That self-referral is so important. Referral to using those accessible services, occupational therapy, heart failure treatment. This is all happening after the crisis. But also the other leg. That's the one thing that people forget. What about this leg here, the so-called non-problematic leg? There's so much that we need to do here, and that's what we got involved with. So it was quite an intensive treatment that she had post-hospital discharge. And the outcome, It is the same lady, it is the same day, but different, slightly different angles. But what you can see now, we've got fine leg definition. She knows how to look after her legs, moisturising daily, wearing those compression garments, keeping on that prophylactic antibiotics, moving more. This lady is now able to walk about. You know, those heart failure symptoms are well controlled because the community heart failure services now are on board and they know how to keep that tempered to a level now. Reduced falls risk now because her legs, the lymphedema has started to reduce. The weight's coming off both the fluid and both fat as well from that dietary input too. Shoes fit a lot better. Reduced pain, so an improved quality of life. I feel a lot better, I know how to look after my legs, and preventative treatment for the other leg too, to boot.
Think about your services, think about how accessible they are. Could you make them more accessible? Are there better ways for people, patients and healthcare professionals to be able to refer into you and to access you? And can you build bridges with other services so that your patients get a better journey? You know, have you got good links with the podiatrists, the diabetic teams, the heart failure team, so that you can get good referrals across to them and that you're referring the right people to them too? Sometimes you might do something little that you're thinking, oh, that'll make things a bit better, and that's really good. When you have a quality improvement that might seem really simple and then becomes standard practice for you, that's what we do now. We found that and it works. Let's keep doing that because that's making things a bit better for us. I can't emphasise enough how important data is. We have this drummed into us quite a lot. Our lead is really pro data. She would say, if you haven't got the data, where's the problem? Where's your evidence that you've got this problem? If you're telling me it, but show me it. And you don't have to generate that data yourself. There's an awful lot of data out there that you can access, through government's things that's freely available. But things like admissions and things like that, we've got a really good link now within sort of Welsh. I don't know where it comes from. The Welsh NHS. Yeah. The data that they just send us every 2 months now. All those people who've been in hospital. We use the SAIL database, which is a GP database. So you can get things like demographics. You can get things like this will show us, and we have the evidence that we see more cellulitis in more deprived areas. We also know that when we send the letters out to people, the response rate in the deprived areas is much lower, and so the worried well are much more likely in the better areas. And so how can we change that? That's my project at the minute. How am I going to improve the response rate to the letter everywhere, but particularly targeting why don't they respond? What stops them responding? Is the letter too high level? Is the language too complicated? Do we need to tone it down? Would they rather respond in a different way? How can we do that? Should we just ring them up rather than send them a letter? Is that cost effective to do it that way? So there's lots of work going on in that. But look at those trends. You might see things that you already thought you would expect to see, or you might just see a little oddity when you're looking at the trends and think, oh, okay, maybe we need to look at doing that a little bit. And the same for your feedback. When you do we do PREMs as well as PROMs, so they're experience measures. So when patients say to you, I found that hospital the right pain to go to, I did the appointment there, I couldn't park, couldn't find the place, the signposting is really rubbish. All those kind of things, take all that feedback and see what you can do to fine tune it. I think this is a key thing, and it's a message that's been used, I think, quite a lot, is the making every contact count. Trying desperately, we'll all be thinking, well, I haven't got time to do that bit because all I've got to do is this bit. But whilst you're having a conversation about something else, whilst you're measuring legs, whilst you're doing something, just thinking about, can I just intervene with something else? Like Joe said, can I treat the other leg? Because they're often the quick wins, I think, with patients. So when you're trying to get them on board to wear compression hose or have a bandage and things like that, if you put them into a really simple stocking on their good leg and they can see the benefits of that because their shoes fit a bit better and, oh, that's quite comfy and it doesn't look too bad, then they're going to be much more likely then to let you do something with that bad leg because they think, oh, maybe she does know what she's talking about. It did work when I wore that stocking, and nobody else had ever bothered with me before about that, and I'd asked the doctor about the swelling and he'd said it was fine, ignore it. And so if you're taking it on board a bit and they feel like they're being listened to, you might get a little bit more support from them then when you try to do it. And then my big thing, which I always try to emphasise when I give education, is that we might say something all the time. So I might have a clinic of 7 people in a day, do that every day for a week, 35 patients a day, been doing that for months and years. So I'm giving these same key messages all the time, aren't I? Saying about, are you sleeping in bed? Are you putting cream on your legs? Can you elevate your legs at all? Are you moving at all? Are you washing your legs? And it can get a bit monotonous, can't it, when you're saying the same things all the time, particularly when you're saying it to an audience that mightn't always be taking it on board, and you're just like, oh, for goodness sake, what do you mean? I've of course you've got to wash your legs. Well, I thought, the doctor said you'd best leave that dry out, so I haven't bothered for 6 weeks to wash my leg. So you are sometimes getting over some urban myths. And I think you can get a bit of clinician fatigue that you're, am I saying this? Is it really worth it? But I think what you have to keep remembering in the back of your head is you might have said it 35 times that week, 350 times in the last, few years, but that person may never have heard that before. And as astonishing as that may seem, because to us it's so common sense because we're saying it all the time, it is not common sense to them at all. And so try and be as enthusiastic about the last one on a Friday as you are with the first one on a Monday, because for them it might just be that moment. And there are lots of people who don't take on board our healthy sort of living kind of advice. We know that. If everybody did, we wouldn't have a problem, would we? But sometimes you just strike them in that right moment, don't you? And if you just catch them in that perfect storm when it's just relevant to them because they've just been in hospital and they were really scared, and so now they are taking on board what you're saying, the knock-on effect of that over the next few years is huge, that you've managed to intervene at that point and make a difference. So I think it's trying to remember that what we see as common sense isn't common sense to them, and not to get overwhelmed with, oh God, we're doing this again. I've told everybody this and nobody listens, when for them it could be an absolute, perfect moment for them. All right, go on, Joe, click next one. So I think that today's theme is, do we have time to care, isn't it? And the whole preference, I think we can't afford not to. When you think about the preventative things that we can put in place that ultimately will save us a lot of time, money, poor experiences for patients if we invest this little bit here. But it's always the bit that's hard to. Crisis management is always where the funding has to go, isn't it? And the preventative health promotion stuff sits on the outside and is a bit of a poor relation. But when you get it right, you have such an impact on the crisis that it's and on the patient experience that I think we can't afford not to. So I think we've spoken quite fast there, haven't we? Thank you. Oh, no, we're all right. It's about 1:45. Any questions, anyone? Go on.
Going more clinical than political or educational, could you just give a 10-point differentiation of wrong diagnosis in cellulitis? So you've got somebody coming, you're not sure it's cellulitis. What are the main points? Can you just
I'd say the main points are probably, and Rebecca Railway will say that really kind of red leg inflammatory pathway.
There's a very good pathway.
Anything that's bilateral. If it's bilateral, you're going to have to really strongly convince me that this is cellulitis. You're going to have a temperature of 39 and be tachycardic before I'm thinking about something. So that would be a big one.
I think the clinical picture as well. What's the patient telling you? How have they come up to that point? The sudden changes. How quickly has it happened? Is it something that you've had for weeks, months, that's just suddenly starting to get a bit more inflamed, or is this something that's systemically?
Acute this morning. And so I think they're probably, and then obviously your big differential for those ones is going to be DVT. So and that's right. I think patients go to their GP with a sudden onset of a swollen leg. They kind of treat both. They're going to give them antibiotics, put them on anticoagulants, send them for a Doppler, and then stop one or the other when they get that. And that's really commonly seen, and I think that's good practice. And patients hate it because I know it's cellulitis because I've had it and I've been for a scan a million times. But if it is a clot and you miss it that day, you're stuffed, aren't you?
And there's lots of diagnostic tools out there as well. The Wells score can help you with your differentials as well to make sure that you're on the right thing. But I think the red leg pathway from British Lymphology Society is so good. We use it a lot. When we're
and what we're doing, our teaching and stuff, and trying to empower doctors and patients. If it's both legs, it's very unlikely that it's going to be. So if both your legs are red, and today they're both a bit redder than normal, it's probably going to be a steroid cream that's going to be needed. I think it might be more painful and things, but it's unlikely that both of those legs will become infected simultaneously.
Compression,
so that's
skincare.
Probably the most common differential, I would say, and that's probably the thing. And we still see it in acute care. You still see people discharged from hospital admitted with bilateral cellulitis, and you're like, really? Do you think they really were? But because of their other comorbidities, and they present and they look unwell because that's what they look like all the time. The risk, it's understandably the risk is there, and then we'll just let them in. I don't know how much they benefit from sitting in an A&E for 48 hours
and then walking out.
But that's probably the most common. Any other questions?
Have you got time?
Yeah.
I just wanted to ask, so I work in a leg ulcer clinic. We're really lucky that we've got good healing rates. The problem we find is when they're discharged, might have a package of care, so on and so forth. We write them a care plan, do all we can do. Is there any literature, just going back to what you were saying about those that are at risk of cellulitis, is there any simple patient literature that we can hand them and say, this is what you need to be aware of, rather than just
We wrote the leaflets ourselves, didn't we, for our clinics, and that's part of that proactive management. Is if there's no literature, write it yourself.
What to look out for.
Absolutely.
Yeah, what to look out for. Use evidence, I would say, so that and relate it to them. Give them a point of access so they can get back in touch and make sure they know what it is. So if they have an acute infection, I'm sure you wouldn't want them ringing you. And we always say that to us, don't ring us, we still do. Don't ring us, you've got to go to your doctor, you've got to go to out of hours, you've got to access us. We'd like to know afterwards, because we would like to know afterwards once you're a bit better, so that we can make sure we haven't missed anything or alter your risk factor management. But the actual acute management is making sure they know what it is so they can recognise it in them. And where they should be going to get that help, and that they should still be wearing their compression if they can. Those kind of things that they might think, oh, the nurse told me to take it off, so I haven't put it on since. And it's, their leg's like this. No, put it back on. You need to get it back on. It's that kind of basic. They told me in the hospital to take it off. That was 6 months ago. Yeah, well, I haven't put it on since.
We've written leaflets for antimicrobial, how to use antibiotics as well, because we were getting people who were given rescue. I just took it for a couple of days and it was fine. So we've got actually, this is when you take it, this is why you take it, this is when you stop. So, and it seems that we get good feedback, you know.
Yeah, we do have leaflets we give to them when we put them on rescue and when we give them prophylaxis so that they have something to remember when it is 6 months later. What do they have to do again? So it's that kind of
thank you.
pleasure. Pleasure. Right, I don't know whether you need. We can't move yet, can you? Because there'll be no space to go to.
Not quite yet. Okay.
It's like school lessons, isn't it? You've got to wait for the whistle.
Wait for the bell.
It's not a bell. It's a whistle. Wait for the whistle, and then you'll be allowed to move. I've got to have some water.
ongoing the prophylaxis for cellulitis? Because